Bronwen.
Hi, Stephanie.
How are you?
I'm fine, thanks. So Stephanie, I just want to start by acknowledging, because I'm in Australia, that I am talking to you from Aboriginal land, from the land of the Gadigal people of the Eora Nation. And I'd like to pay my respects to their elders past, present, and the elders of the future. It's a tradition that's developing in Australia as we deal with our legacy of colonisation. So it's something that's great to be able to do for people across the world.
Well, that's lovely. Thank you for starting with that. I've been looking forward to speaking with you, Bronwen. The DMM community has a range of different clinicians and academics and students with different backgrounds and different specialisms. But there are some things that we share in common. I think one of those is that we're all fascinated by humans. And another is that any group of people that we apply the DMM to will have at some point been infants. So that sort of brings us to the topic that we're going to explore today. I've been advised from some reliable sources that you are a good person to be speaking to on this topic. And I wonder if you could start by telling us a little bit about your professional background.
So I'm a social worker. I have spent my whole career, which started, it feels sometimes like in a different galaxy a long time ago. I spent my whole career working in different ways with parents with children who are at the pointy end of the system, if you like, people who have got the child protection system worried about them and are struggling then with the implications of that kind of scrutiny. And so I've worked as a child protection worker, I've worked as a family therapist, I've worked as a manager of a foster care and residential program. And then for quite a long time, I've worked for myself, which is really nice, I have to say. And I've what I do is work with organisations that work with children and families, and I also do assessments in our children's court system. So I'm meeting with parents, often in their homes, seeing them with their children, and trying to work out in a pretty short period of time, is it safe for this child to go back home? What's the likely trajectory if they go back home? What might we be able to do that might be able to change that trajectory? And what might it take for this parent and their family to be able to engage so that the things that we're worried about in relation to this child and the knowledge that we've got about what's happening here might have meaning for them, so that they might actually be engaged, not just in doing things because our eyes are on them, sort of the hostage terrorist approach to family change, but what can we do so that this actually makes sense for them and things can be different.
And what led you to be interested in this type of work?
That's a really good question. Actually, my mother was a social worker. And I think it's hard for people to remember that back in the 70s, there was still pretty limited views, certainly in Australia, about options for women. And I didn't really want to be a teacher and I didn't want to be a nurse. And I thought about law, but thought maybe that wasn't going to work out so well. So it didn't feel like there were an awful lot of other options. So I feel like I fell into it, and I'm still here. So I wouldn't want to overthink the fact that it was my mother's choice as well. But post feminism, you know, maybe there are a lot more choices.
Yeah. And before we get into the wonder of what human infants bring to this world, I wonder if we could start by just defining some terms. So let's begin with attachment. What does attachment mean in infancy?
So so attachment to me is and I think this is hopefully informed by a reasonable understanding of what John Bowlby and Mary Ainsworth meant. Attachment is the process by which infants survive, because attachment is about eliciting the best available comfort and protection. And we know that infants can't survive unless they have somebody who is paying attention to them. Unless they've got someone who, when they cry, will respond, will feed them, will make sure that they're physically safe from whatever's dangerous out there, and will nurture them, because we know from the horrific experience of children who've been in orphanage care without attention, because they had nobody who had the capacity to look after them. We know that those children don't do well, and that a lack of an available adult in the early years of life is critical for your neurological development. You actually need to have the stimulation of a responsive adult for your brain to grow. Yeah. So attachment is the process of that relationship developing between a child, and it doesn't have to be just one person. If you're fortunate, you've got a few people who have that investment in your development, but you need to have at least one. And so attachment's the process by which children in infancy develop those predictable expectations with another person. And of course, that involves the other person having that expectation that they will be responding to the cues of that infant. And it's absolutely critical for survival. So Winnicott said there's no such thing as a baby, because if you're just a baby and you don't have someone there who's paying attention to you, you don't have the capacity to survive.
Yeah. Many people who are watching this may have trained in some of the other measures of attachment at different stages in the lifespan. So, for example, the adult attachment interview. How do you think of attachment in parenthood?
So I think what you bring to the task of parenthood is your experience of having attachment relationships. So if you were fortunate enough to have parents who were responsive enough so that you knew what you expected from them, and you were more or less comfortable and safe. And I think one of the beauties of I'm trying to work out. So I'm going to say Pat, but that feels very formal to someone whose work's been so influential. But because we're in a community that's only here because of her, it kind of also feels that that's okay. one of the beauties of her work is that recognition that many of us won't have parents who were perfectly attuned. Perhaps none of us have parents who are perfectly attuned. And that parents do the best they can in the circumstances that they're in. So we're not necessarily talking about parents who are always going to be sensitive to you, but we're talking about parents who are going to keep you safe and comfortable enough that there's not going to be a significant cost in terms of your own capacity to know yourself and to be able to nurture other people. And so the attachment relationships you bring will then impact on how you raise your child. If your early attachments involved harsh parenting or unresponsive parenting, or if you had a parent who was very demanding of you, then you're going to bring that experience to parenting as well. And one of the real challenges that we see all the time in child protection work is that you might know that you don't want to be the same as your parent was. And parents in child protection interviews will often tell me that, and you'll ask a question like, so, tell me in what ways you're aiming to be a similar or different parent to the parent that you had. And they'll say, I'm not going to be anything like my parent, like my mother, my father. And then what'll happen is that what they've ended up being is just the opposite to the parent that they had, which also is problematic. So that they won't necessarily be able to integrate that information about not wanting to be harsh and then becoming sensitive. They'll not want to be harsh, but then become laissez-faire. So that from having a parent who never let them, it feels like never let them take the lead, who punished them all the time, you end up with a parent who is completely laissez-faire and potentially quite scared of their infant strong feelings, so that they really struggle with boundaries and paying attention to their child's safety and to their role as their child becomes older in negotiating with them and working out how their child's going to transition to independence. So of course, attachment isn't destiny. So there are lots of people who haven't had great experiences in terms of their attachment to their parents, who are able to work through that process and find themselves where they are parenting in a different and more sensitive way. But it's challenging. And one of the difficult things, I think, is that it can catch you up, so that parents are often not prepared for what having a child is going to bring. Yeah. They're not prepared for how they're going to feel, and they're not prepared for having to revisit some aspects of their life that they thought that they were leaving behind. So it's a really challenging process.
I know that you mentioned that one of the things that children do when they first come into the world is try to survive. And it's interesting because when human infants are born, they look so, I suppose they are so physically helpless. What innate wisdom do they bring into the world with them?
Well, they bring an extraordinary amount. I mean, when you think about the fact that that unlike a lot of other species, infants can't actually find their own food. Just that huge thing. But they can cry. so they can signal that they're distressed. Within the first 6 weeks, generally, they will be able to connect with their parent using their eyes and their smile. And so they'll be able to show a parent when they feel happy to be with you. And that's incredibly reinforcing, so that so people can have those moments of feeling like, I am enough. You know, even if at 2 o'clock in the morning my baby is screaming, in this moment, there is no one else I would want to be with. And I just feel awesome. So, which is incredibly important in terms of baby's survival. You know, people sometimes laugh about this, you know, it's so good that they're cute, but it is so good that they're cute. You know, babies' eyes proportionately are bigger than adult eyes, and you know, we respond to that. It enables them to signal more powerfully, and that's really helpful. And pretty quickly, they're going to be able to use their hands to reach. So they're going to be able to reach up to their parent well before they can walk. They're going to be able to reach up to their parent and signal that they want to be with you. They're going to have some reflexes. So early on, there's going to be some movement that they're going to be able to make, which parents might find entertaining. It's not necessarily, sometimes parents think their babies are cleverer than they are, but that's not particularly a problem. That's probably a good thing. But they're also going to start developing some more organised motor responses. You know, by the time they're 6 or 7 months, they're going to be able to sit up. Even before then, they're going to be able to roll over and grab things. So people are going to be able to play with them, because they're going to be able to do things in response to a parent, and they're going to be able to find their way to their parent once they can actually move crawling on the floor. They're going to be able to move to their parent and remind them that they're there, should that be necessary. So well under the age of 1, they have a whole lot of strategies available to them that are very much cued to that relationship. You know, human infants are still, certainly by the age of 1 and even older, going to be quite dependent on adults to be able to find food, but they're going to have a whole lot of strategies to remind that adult that they're hungry. And so there's so much complex development that takes place during that first year or so of life.
What are the key things that they need from their parent during that first year? You've touched on some of this, but what would you say are the key things?
Well, obviously, in terms of survival, and I think in the West we take this for granted, but in terms of survival, they are going to need to be fed. They're going to need to be in a safe environment. And again, in the West, we take this for granted, but they're going to need access to a clean environment, because they've got vulnerability to disease. Their immune systems haven't necessarily developed. They will have protection if they're breastfeeding. They're going to need opportunities to interact with their attachment figure, feeling safe. So I love the way David Howe, who's an English social worker and writer, talks about attachment as borrowing the adult's state of mind. And so for infants, they can't discern what's happening around them. They don't have language in the first year in the way that will start to develop further down the line. So they've got a limited capacity to use words to make sense of what's happening and to communicate. So they're really dependent on their parent state to signal to them, is this safe? Is this comfortable? So if their parent is physiologically comfortable and available to them, you know, looking at them, talking to them with a voice that's in a comfortable range, that signals to them that everything's fine, and they can be themselves comfortable. They don't have to be particularly vigilant. But if they don't have a parent who is themselves comfortable, if their parent is alert or their parent is angry, or their parent is depressed, then the infant's going to pick up all of those complicated signals, and they're using that information to make sense of what's going on around them. So in child protection, parents will often say, you know, yes, my partner and I were having really big arguments and I was being threatened, but I actually didn't think it was bad for the baby because the baby couldn't understand what we were saying. And of course, from a child protection perspective, we're thinking is, yes, but the baby felt what you felt. So if you were scared, then the baby's going to be scared. You know, if you're angry, then the baby has to deal with that complicated arousal state. And of course, again, I think one of the very significant things about Pat's work is that she identified the idea of compulsivity, where even a young infant may inhibit signaling their distress in a situation where they learn quickly that it's too dangerous for them to do that. So if an infant's in a situation where a parent is highly negatively aroused a lot of the time, or is really scared in the case of a situation where there's domestic violence, if their mother's really scared a lot of the time, then they may learn that they need to inhibit their crying. And over time, and this happens so early, you know, we see it on video with infants in the first year of life. They start to replace their true signalling of feeling with a false signalling in an attempt to make things better. Not in a fully organised way, because they're too young to do that and they don't have language and they don't understand what's going on. But they start to shape their responses in a way that will not prioritise their own protection and comfort, but will get them the best protection and comfort that's available. So they're not signalling how they really feel, but there isn't space for how they really feel. So to get the best of what's available, they have to carry the cost of that. And it's understandable, very understandable that parents don't recognise that because they don't think, because their baby can't talk, they don't think that their baby can have an understanding of what's going on, and they don't recognise that whatever their state is, you know, when they pick up that baby actually picks up a whole lot of information.
So whilst the baby doesn't have the capacity for language, it knows at an implicit level in the body.
Yeah, and I think that's thinking about arousal states is really helpful. So that it's really difficult for the baby to be in a comfortable state of arousal if they're being cared for by someone who feels very, very uncomfortable, either because they are highly aroused because they're fearful or angry, or because their arousal is low, because they're depressed. So if you're in a highly aroused or not aroused enough state, you're not responding to the baby in that sensitive, attuned way. And just your body feels different to the body of somebody who's comfortable. You know, if you think about what your breathing's like, what your heart rate is like, you know, there's that information. And the level of tension in your body. So if you're stressed, your body is going to feel different to the body of somebody who doesn't feel stressed. And it's going to be less comfortable for the baby.
Can you describe what compulsivity looks like in an infant?
So in early infancy, and on video, you can see this in the most endangered babies. So infants who have had such extreme exposure that they're starting to organize that behavior, even under 3 months. In infancy, there's a couple of pathways. Probably the most common one is infants who have a parent or the exposure to danger where there's a lot of information given through even through physical abuse of the baby, so punitive responses to the baby, so shaking the baby or hitting the baby or yelling at the baby frequently. So what you see is babies who inhibit all the negative information that they can. And when you see those infants, you see in their bodies that they're tense. So they don't sit comfortably or lie comfortably. They have tension in their bodies. They are not comfortable looking at their parents, but they can't look right away. You often see that their mouths are open, but there's no sound coming out at a point where you might expect them to be vocalizing. So they can't scream and they inhibit that vocalization. Or you might hear a strained vocalization, which people can often think means, oh, they're excited, but is actually the scream that they can't let out, strained so that it sounds more positive. And you'll see them be very quick to pay attention to what their parent wants to do. So in play, they don't choose to do what they want to do. They take whatever their parent offers. And you'll see these gaps where it's like they're trying to work out what to do next. So in infancy, unlike the preschoolers, you'll see that it's not smooth. So it's like a package of bits and pieces of behavior that aren't yet integrated. And in terms of attachment, we don't see attachment strategies in a way in which they can be reliably assessed with a procedure like the strange situation. We don't see them clearly enough till infants are about 10 months. So in that first year, they're still developing, and certainly their compulsivity is also developing. And so it won't look smooth in the way that it does a little further on. The other thing that we see is that before they're compulsive, these infants are often quite difficult. So they will cry a lot because they're uncomfortable, because they're highly aroused. And so you'll see a pathway sometimes when you're taking history where parents will say, well, they were very difficult in the beginning. And that might be interpreted as reflux. So people will say there was a lot of reflux, but then things improved a lot, once they got to 3 or 4 months. and after that, things have been much better. And from a DMM perspective, you might start hypothesizing, I'm wondering what was happening, given the infant that I see now who seems to be quite inhibited and or is showing these signs of positive behavior that don't seem comfortable, then that early period, the parent might attribute to reflux, but I might wonder if there was a relational component to that. The other pathway, broad pathway to compulsivity, can be in infants whose parents are not responsive. So if you think about infants who, some infants have lots of negative stimulation, it's punitive stimulation, and that's the pathway to inhibition. The other pathway can be infants who don't have stimulation. So their parents are depressed, they're not paying attention to them. If they do pay attention, they're not sensitive to their cues. And so those infants can learn that it's not actually a good idea to protest. So if you cry a lot, mum finds that overwhelming or dad finds that overwhelming. So they put you in a room and they're somewhere else. But if you are able to start smiling a lot and making positive sounds, then they might pay more attention to you. And so those infants learn to inhibit their distress cues and increase their false positive cues, so that they have, you'll see them smiling in a strained, uncomfortable way. You might hear the strained, uncomfortable vocalization. You'll see that the quality of their eye contact is different to sensitive and cooperative dyads. And you can sometimes see them make extraordinary efforts to do something that might actually be quite demanding for them, but to do something that will attract their parents' attention or keep their parents' attention, because they can't expect that their parent will attend and wait for the child to organise a response. So that generally takes a bit more time to develop. And so those infants may look quite passive early on, because there's nothing they do that makes a difference. Crying doesn't work, so they just can't organise much until we start to see them organising what later on may function as a caregiving strategy, where the child inhibits their own negative feelings and does things that hopefully activate the parent, so the parent will respond to them.
When you see the parents' infant dyads and you see the compulsivity in the infant, do you notice the dyadic effect with the parent? So can you see the ways that it makes parents better parents?
Yeah, so I don't want to minimize the challenge of identifying compulsivity. So it's the big challenge for people who learn the Care Index, is identifying compulsivity. Mind you, that's not surprising. If you read Raising Parents, Pat talks about significant child protection crises where children who were incredibly endangered were missed. Older children than the children we're talking about, perhaps children who are 5 or so, but everybody missed the fact that these children were being horrifically abused because they had a smile. If you look at some of the situations in the UK, like the baby BP situation, you can hypothesize that people who see endangered babies miss those signs because the mother's saying what we want to hear and the baby seems to be smiling. And our understanding is, well, if you're smiling, you must be okay. And so people don't get the quality of the strained, false quality of that smile. And so compulsivity is really, it's often missed, and it's missed, you know, even when people are looking at a video. It's easy for us to miss the level of distress of the baby, because of course that's what the function of the pattern is. The function of the pattern is for people not to get overwhelmed with the baby's distressed feelings, but to feel like this baby is someone that you would want to respond to, that this baby is doing something that makes you as a parent feel more comfortable. So when you're looking at infant dyads, there's so much information in the video. One of the challenges is that you have to reduce that. You have to be able to reduce the information that you're seeing to something that you can make sense of. So sometimes what you'll notice is the baby, sometimes what you'll notice is the parent. But what you're seeing when you're looking at compulsivity or something that tells you this isn't working so well is a discrepancy between the mother and the baby. So you might see a very active, smiling mother with a baby who doesn't seem to be enjoying the interaction to the same extent that the mother is. Or you might see a mother and a baby where nothing's happening. And that's a cue to you that something is odd here because, for example, with the care index, we just say to people, play with your baby the way that you usually would. And so if what somebody does then is just to lie the baby down, sit next to them and fiddle with a rattle, that doesn't really fit with what we've asked them to do. So I think discrepancy is always the thing that I'm thinking of when I'm looking at interactions. And sometimes that discrepancy will be a pathway to identifying compulsivity.
Based on what infants bring into the world, do some of them require more skilled parents than others?
This is a really interesting issue, and you know, there's a whole lot of temperament research that is looking at the idea that some children are more difficult to parent than others. I think, you know, clearly there are children who have a difficult start to life. So there are premature infants, for example. So there are, you know, there are clearly situations where some children are going to be in a less comfortable state than others. I do think when you think through a care index lens, the question you ask is, so given what this parent has come to know about their infant, what are they able to do with that information? And one of the interesting things with the care index is that we can see videos of different adults interacting with the same child. And you can see extraordinary differences between the way a child will respond to one adult and another adult. So yes, clearly not every baby is the same. They've all had their own pathway, even through the prenatal period. And if you look at, you know, infants, for example, who are born substance dependent, you know, there are very clear examples of situations where they will have to be more difficult to parent. And I guess the challenge is, I wouldn't, having thought about this from a DMM perspective, I just wouldn't say that if a parent tells me their child is really difficult to parent, if they say, I know they've got a really difficult temperament, I just wouldn't assume that that's the only information that's important. That I think that's what the lens that the DMM brings.
Do you see in infants who've maybe been exposed to domestic violence or substance misuse and so on in the womb, when you see them in infancy, do they look like they're more challenging to parent? Do you look and think this baby requires like a skilled parent?
I think it depends. So I think there are children who, if they are used to no one paying attention, then that experience starts to shape their expectations. So that's going to make a difference. If they are very aroused, then they're going to need somebody who is going to be able to soothe them. And not everybody has good skills in that area. People will tell you, I don't know how people who work with children can do it. So I think humans are complicated. I think what the dyadic lens brings, though, is the understanding that what we see in the baby isn't just contained within the baby, that there's a dyadic frame to that, and we just need to be careful not to hold babies fully responsible for everything that's going on, because they can't exist without that relationship. So we need to be asking ourselves what's going on in that relationship.
Yeah. And when children are learning to regulate their affect, what are the key things that help them get to a state when they can regulate their own affect?
So I love the definition of sensitivity we use in the Care Index, which is, it just says that sensitivity is a parent doing whatever is going to soothe the baby if they are overly aroused, and draw the baby's attention in a way that's comfortable for them, so that they're able to engage and play. So I think that's a really helpful way of thinking about the relationship. So when does this baby need to be soothed, and what are the things that are soothing for them? And of course, then what are the challenges as a parent? If you're struggling to stay calm, then what are the things that will help you stay calm so you can better soothe your baby? Because it's really difficult. If your baby is really dysregulated and in a heightened state, and you're following that heightened state up, it's going to be really difficult for you to soothe that baby. So what are the things that are soothing? And then what are the things that are comfortably stimulating? And again, one of the things that the Care Index gives you is an awareness that things that we like to do to babies are not necessarily things that are comfortable to babies. So we do a lot of shaking things in babies' faces and teasing babies. And there's a whole repertoire of behaviours in different cultures, which may or may not be things that this baby likes. And you were asking before about, what does it take? What does it take with different babies? And the question is, well, what does the baby like? Because different babies will like different things, but nobody's going to like things that make them uncomfortable. So just looking at what this baby needs for them to pay attention, and then as they're developing after kind of the first 3 months, what does it take for there to be some kind of turn taking? between them and their parent. So very gradually and gently, the baby starts to make a contribution to the relationship, and it's not entirely dependent on its parent for managing everything that's happening.
Can you think about some examples that, and this may not be the case for everyone, but that tend to be effective in regulating an infant's arousal?
So some of that depends on the age of the baby, because one of the things that happens in the first year of life is babies grow a lot. So what's physically possible to do with a newborn may not be as easy with an almost 1-year-old. But physical positioning and body comfort is where you'd start. So physiological regulation involves how you're actually using that body connection. And if a baby is distressed, sometimes changing their body position, perhaps moving them to a more upright position, can be helpful. So getting the connection of your body and the baby's body and getting that full connection. Gentle movement can be helpful. And again, that's about physiological regulation. We think about as adults how comfortable movement is comfortable and soothing for us. So that's the same as it is for babies. A hungry baby is always going to be uncomfortable. So, you know, those things that people say to new parents are totally true. You know, check if they're wet and they need to be changed. You know, check if they're hungry, but also recognize that babies can be distressed and not be hungry. So, so they may need comfort without necessarily relying on food.
One of the things that I like from the Attachment and Family Therapy book is this notion that whilst initially the baby may need the mum or the dad for physical comfort, and then gradually as the child is getting older, that it may be that hearing the mum's voice may help downregulate, or it might just be hearing footsteps.
Yes, and I should have added soothing voice, comfortable face to that list. And of course, that's why we sing lullabies. You know, I think singing helps adults regulate. Mm-hmm. So if we're singing, it may be easier for our voice to sound soothing than if we're talking. And of course, then we don't have to think about what to say. So I don't think it's a coincidence that lots of different cultures have these songs that are what we sing to babies, and they're part of the cultural repertoire.
Stephen Porges talks about that within his polyvagal theory, where he talks about the prosody in the voice, so the ways that it sort of goes up and down, has a regulating effect, and that it can bring the social engagement system online and have that sort of soothing, regulating effect.
And when we were talking before about discrepancy, I think that's one of the things you notice in dyads where it's uncomfortable, is you don't have that comfortable variation in the voice. People are all up or all down, or they're going from being right up to being right down. You're not actually getting that beautiful flow that you get with a comfortable tone of voice.
And it sounds like in those sort of examples that the baby's just picking up something doesn't feel safe here.
Yeah, I think the word discomfort is so helpful. You know, that the idea that there's an absence of comfortable connection, and babies are just so incredibly alert to that information.
Yeah. What would you say are the main sorts of interactions that lead to parent infant dyads coming to the attention of professionals?
I think there's a whole lot of different ways that people can come to attention. And the reality is often people don't notice what's happening with the baby. So I think one of the challenges in our work is actually being able to make sense of what's going on within the relationship, because often what people have noticed is the things that are affecting the adult function, like domestic violence, like substance use, issues around the parents' mental health. So parents who are not in a comfortable state, because if you have mental health issues, that's one of the difficulties, that you can't maintain a comfortable state. Sometimes people will notice, I think the really frank things are things like children not thriving physically. So children who aren't being fed regularly, or who parents experience as being hard to feed. So children who are underweight. I think people will sometimes see, it's interesting, sometimes I think what people see is not a concern about children's reactions, but a concern that children aren't reacting. And this is actually sometimes the police will notice this, that they'll go to a situation where there's a very violent argument going on between the adults, and the children just seem completely unaffected, as though it's so common for them, and we would understand that as, so they've organized a strategy so they don't pay attention to those adult cues, because that's not safe for them to respond. So sometimes that discrepancy will be what people notice. I think sometimes people will notice the discrepancy of an adult being angry with their child. So they'll notice that a parent is losing their temper at a child. And I think it is significant when adults, particularly adults who know that they're already under some scrutiny, really lose it with a young child, because it tells you something about the difficulty they're having inhibiting their own negative reactions. So particularly if you're in a government office or in a social welfare office of some kind, and people see you being really angry with your child, that is quite significant information, because most people would recognise that, these days would recognise, certainly in Australia, that those people will have some mandatory reporting responsibilities, and they'll be alert to how they present in that situation. So that sort of discrepant behaviour, really being angry with the child, or being angry around the child, or really being inattentive to the child. I think those are the things that people kind of tend to notice. And I think they notice the adult behaviour much more than the child behaviour. So that's one of the challenges, that sometimes what's going on for children might be missed.
Yeah. I wondered if you could talk a little bit about the care index. I know we've touched on it.
Yeah, so I've actually got a PowerPoint that just might help me to keep track of my thoughts. So I said before, we think about sensitivity within the care index as any pattern of behaviour that pleases the infant and increases the infant's comfort and attentiveness, and reduces its distress and disengagement. So the care index is a procedure that's based on play, and you can use it with infants up to the age of 15 months. There's a toddler version which has similarities and is used for children who are older. Its procedure is slightly different, so I'll just focus here on the infants. You just ask the adult, who just needs to be someone who is known to the child, to play with the baby the way that they usually would. And you video that, and then that's the end of the collection of information. So the care index is focused not on attachment. As I said before, you don't see clear information about attachment strategies until infants are 10 months. So the idea of risk is that you're looking for the kind of pattern of interaction between the adult and the child, and you're thinking about, is that a sensitive and cooperative pattern, or is it a pattern where we can see some risk in the relationship? From a child protection perspective, you might be thinking about, can we see patterns that might be associated with physical abuse? Or you might be thinking about, can we see patterns that might be associated with neglect? The care index can't substantiate those child protection concerns. So you can't watch the parent and infant for 3 minutes and say, well, that child is being abused and the statutory organisation needs to intervene. But what it can do is give you a way of understanding that relationship that you might be able to use along with other information to think about, how worried do we need to be about this parent and child, and what might we be able to do to help them change. And what you do is look at different kinds of information. So you look at other videos that are known videos of parents and children. You think about, what is the synchrony between the parent and the child? Are we seeing lots of cooperative, sensitive synchrony, or are we seeing something that is insensitive? And we think about different kinds of insensitivity. Is there a pattern or a way of understanding how that functions? And then you end up producing a series of numbers that you can put in a spreadsheet if you're looking at doing research. And the other thing that you bring to the care index is your gut feeling. So what's fascinating looking at the care index is that sometimes you can look at a video and pretty much you could show it to a person in the street and they would understand this is something to be concerned about. But sometimes there can be situations where children are quite endangered, particularly children with a compulsive pattern. And many people would look at that video and think this is fine, because we all bring our own kind of preferences and our own experiences. And there's often a natural reluctance to actually say this really isn't working. It's interesting how unreliable our gaze can be. So the care index has a synchrony scale, which is on the screen now. What I want to emphasize with that is you give a number in terms of synchrony, and between 7 and 14, so half of that scale, we're basically saying, you're doing fine, thanks for coming. We're not looking at intervening unless there's something you want help with. And something that Pat really emphasises is that we can't assume that intervening with people is actually going to improve things. So if the evidence is that people have found a reasonable way to be together, then we don't want to be trying to tell them that what they're doing isn't good enough. We don't have the evidence that we actually know how to do it better.
Among the people that you assess in the context of care proceedings, how many, like what sort of percentage would you say come into that adequate or no intervention required?
I haven't necessarily done care indexes for those in our jurisdiction. Mm-hmm. But when I've looked at videos for parents who are involved in care proceedings, and this would be my experience of the parents that I've worked with, I would say it's unusual, very unusual, to find people where the child protection system's been involved, and certainly by the time I see them, you're not going to be having sensitive and cooperative interactions. thinking of the range of people that I've worked with in the child protection system, there are a handful of people where I don't think there should have been statutory intervention. Mm-hmm. So even though there was quite significant statutory intervention, I do think sometimes the system can get it wrong. But it's a handful in, you know, hundreds and hundreds of families where I've assessed them. And yes, I don't think it's common, if I think about the broader range of Care Index videos I've seen, I don't think it's common that people are incredibly worried. And we look at the video and go, no, they're a fabulously sensitive dyad. Yeah. So I think what's probably more likely is that people think that people are doing better than they are. You know, I think there's a kind of natural tendency in the helping professions to assume that it's all going to be okay. And I know sometimes some work I've done with people who work with children and families using the Care Index is that people have been working with families who are struggling, and when we've looked at their Care Indexes, they've come in the struggling kind of range, which has seemed perfectly reasonable and what you'd expect to me. Mm-hmm. And it's been a bit of a wake up for some of those workers that actually, yeah, we wouldn't expect this, you know, young mother who's been homeless and had a history of trauma. We wouldn't expect her to be able to behave with her baby the same way as somebody who's had a very comfortable, easy, well-resourced existence. But that doesn't mean that mother and baby aren't going to be okay. You know, so actually, if you've had all of that difficult experience and within the Care Index, we're saying you're struggling, that's actually a really good outcome. You know, some good things are happening here that we can build on. You know, if they're in a, you know, a supported accommodation service and they're doing incredibly, you know, they're incredibly sensitive and cooperative with their infant, I'd be seeing that as a discrepancy. I'd be thinking, you know, so how did you manage to get here when all of this other stuff has, you know, the community has let you down in so many ways? So I think it's one of the things I really like about Pat's work, that you understand the parent and the child in the wider social system. You know, being homeless is incredibly stressful. And so that is going to impact on your relationship with your baby. You know, you don't need a group parenting intervention. You need a house. That's what we need to be doing with you. And, you know, in the child protection system, if we're judging you for the relationship you have with your baby, but we aren't giving you any help to actually get to a safer place, then we're really missing the point. Yeah. Now, not everyone who has access to that safer place may do as well as we've hoped. That's a whole other issue, but you can't be comfortable with your baby if you don't know where you're going to sleep tonight or this week. You know, it doesn't make sense.
That brings up the question that Pat often asks in terms of where is the danger, and we need to try and make things safer before we can look at
change the danger, not changing the child. Yeah.
Thank you. I'll let you go back to the slide. I was just curious.
Yeah. That's okay. And I won't have too many. There you go. So I just want to highlight with the scale that while it isn't a colour by numbers procedure, it's got some implications about the kind of intervention that might be helpful. So if we feel that you're struggling, and that will be quite a lot of parents, the question is, what can we do with you that might be helpful? So we're looking at something that's voluntary but's going to work. And that could be a parenting group program, as long as it's something that is sensitive to you. I think that's a huge challenge with some of the things that we offer to parents and infants, that we offer them a one-size-fits-all intervention that doesn't necessarily end up helping that parent to be more sensitive. It may just help them. If they weren't very active, it might help them to do more. But if you don't do things that are sensitive to your infant, that isn't actually going to improve the interaction. And then within the high risk group, we're not necessarily thinking here about high risk in terms of child protection intervention. We're thinking about high risk in that the information we've got about the relationship suggests that the trajectory for this parent and child is going to be challenging for their relationship and therefore for the child's development unless something changes. So 3 to 4 would be suggesting that needs to be an intervention with the dyad that is sensitive to that intervention, to that dyad. So, you know, one of the examples might be video interactive guidance. And obviously also that if there are dangers in the family's environment, then we need to be looking at helping the family to access the resources or the things they need to reduce those dangers so that they're able to be more sensitive to their baby. And at 0 to 2, we're looking at, right now we can't work with this mother and baby together. We actually need to work with the mother or the parent so that they're in a more comfortable and safe place. And that might mean we need to look at who else is there in the family or in the home who can help take care of the baby. And it means more active involvement, perhaps, of services like mental health services who might be able to assist the parent in terms of the issues they have with their state. So as I said, not that that's completely prescriptive, but I think it's a useful way to think about why are we doing what we're doing. And I certainly see situations where there are very significant issues for parents and the system response seems to be, well, everybody needs to go and do some psychoeducation. And I just find this framework really helpful in being able to explain to people, you know, this is why an intervention like Circle of Security is not going to make a difference right now. You know, a 6-week psychoeducation about security is not going to help when this parent is feeling so unsafe and dysregulated themselves. So I just wanted to show you this framework, which is around the play task. It's a really lovely way of thinking about the way that children's capacity and therefore parents' sensitivity changes from that very early period where we were talking about, you know, everything is about physiological regulation because you actually need all of that physiological support to be ready to play. Through being able to, I think there's an error here. I've got turn taking and playing the game around the wrong way, my apologies. But you look at beginning to take turns, playing more complex games like peekaboo, starting to be able to introduce toys where you're both attending, and then being able to incorporate language. And then I just wanted to talk a little bit about patterns, just to explain the idea visually that within the Care Index, there are different ideas of patterns between infant-child relationships. And the last time I was in Italy, I just saw some fabulous pictures in some of the Italian art galleries. So here are some ways of explaining some of the interactions. So we talk in the Care Index about responsive versus unresponsive, sensitive versus insensitive. And this is a picture of someone who is unresponsive and insensitive. So you can see how far the baby is down on her lap. There's no connection between the mother and the baby.
That baby isn't very happy either.
No, the baby isn't enjoying this. And many of the babies in the Italian masters don't look like they enjoyed the experience, which is hardly surprising. Here we've got another one. So we've got another baby who is clearly not happy, and you can see the little hands on the mother's wrist, kind of pushing the mother away, and the mother's tickling under the baby's chin, and just look how grim her face is. So in the care index, we'd be thinking about, this is a responsive mother. She is doing things to the baby, but she's doing them insensitively. So you have the two poles of responsive and unresponsive, and you have insensitivity. And I have to say, it wasn't easy in my art gallery tour to find sensitive and cooperative pictures. This is probably my best example. So this is an older infant, and the idea is the baby doesn't need to know to look at the mother, because he's had so much experience of knowing where the mother is. But I just like the mother's watching, and the baby is watching in the same place, and the mother is supporting the baby, the hand is on the baby's body, and there's a nice warm feel. So that idea of connection, and the sense of attending, joint attention, so that they're both looking in the same place. So that's my best example of sensitive and cooperative in the art galleries of Florence.
Oh, that was really interesting.
So I think that just gives you the idea, though, of those ideas of the patterns. So sensitive and cooperative, responsive versus unresponsive, the idea of sensitivity versus insensitivity. It's more complex than that, but that framework enables us to make sense of intervention. And the idea is that if you have somebody who is responsive but insensitive, you need to help them change how they feel when they are with the baby, which might involve looking at some of their experiences, the things you talked about in the beginning about what do parents bring to attachment. Mm-hmm. And if you have someone who is insensitive in an unresponsive way, it might be, if the synchrony is very low, they might need help to actually be more active, but active in a sensitive way. If the difficulty is that they're just missing the baby's cues, they might need help to change the activity that they're doing with the baby, so that there's more information for the baby and more opportunities for connection.
That's so interesting. What would you say are, you've touched on this a little bit, but what would you say are some common mistakes that professionals make when working with families with the types of difficulties you've just described?
Yeah. I think managing our own distress is really challenging. So I think just as parents overreact and underreact, I think we overreact and underreact. So, if we have somebody who's really stressed, child protection intervention is incredibly stressful. So sometimes then we see people on the worst day of their life and we assume that's their complete capacity, and that's really unfair, and it's not helpful for parents and children. So, I think looking at what is the most helpful way to try and help people is something that's really important. I think the other thing that can be difficult is that just because we really want something for somebody doesn't mean they're going to want it for themselves. So I think something that's very difficult for people working in child protection is when you're invested in work with a family, it's actually recognizing that just because the parent says the things you like to hear doesn't mean that things have actually changed in the relationship. And in fact, sometimes I think we set people up to fail because we inadvertently coach them to say the right words, and we put them in interventions that teach them the right words and that give them the idea that if I say these words and I talk about sensitivity and security and regulation and safety and boundaries, or whatever the words are, that then I'm actually being the parent you want me to be. And so then we come along afterwards and say, well, no, you've done really badly. And that's really confusing for people because they've done the things that we wanted them to do. And if we offer people interventions that, thinking about this from a DMM perspective, if it's primarily what we're doing is just semantic, then that's actually our responsibility. We need to be intervening with people in a way that is sensitive to them, and then is going to help them to be sensitive with their infants. So, I think those are broadly, they're the things that I see that are the biggest issue. I guess the third area, I think systemically everyone in child protection is really working on this. I think we know historically child protection's been really punitive and judgmental. So, and I think people still have those experiences where people get angry with them and hostile, that's their experience. And, child protection is it's so much a failure of the community. It's really unhelpful for us to, even though we have to operate with individual parents and children, it's really unhelpful for us to behave as though people set out personally to do things that were harmful for their children, as though they had their child so that they could actually hurt them. That's not the way it works. So I think that's the other challenge, managing our own anger, sometimes in the face of what parents have done, and sometimes just in the face of what our job requires us to do, and looking at ways that we support people doing these really difficult jobs so that they're actually able to be sensitive to the people that they're working with. And that's really challenging when sometimes you are going to have to make really difficult decisions, and you are going to have to recommend that people can't raise their children.
If there are any professionals watching this just now and they're struggling with that very issue that you just described, they're finding it very hard to connect with feelings of compassion for the families they're working with, what advice would you have for them?
I think we're talking here about the importance for infants regulating with another person. And I think the only way to look at managing better doing child protection is to look at doing that with the support of other people. So I think people need to be doing child protection as part of a community, and they need to have people who are able to support them to do that work. So whether it's telling your manager that you're really finding something difficult, if that's safe, or getting external supervision, or finding some peer networks. I think you need to look at those changes happening in relationship. And I think the other thing, people need to look at is just how challenging it is doing those front end jobs. And, maybe it isn't something you can do forever all the time. And you shouldn't be punishing yourself if you get to a point of feeling like this is really hard. So I think there's a distinction between having that experience in your first 6 months, in which case, I'd encourage people to look at how do you work through that, and having that experience after you've been doing it 10 years, at which point, I think it's very reasonable to look at how can I have a sabbatical, which might not mean I leave this permanently, but it means that I've seen a lot. I've been through the wars, and I need to look at having some safe and rejuvenating experiences. But I only survived my child protection experience because I was fortunate enough to have a really active advocacy group at the time. So we were actually doing political things as well as actually going out and seeing families, and keeping that perspective around the limitations of one-to-one child protection as a solution to systemic political issues. And I actually found that support incredibly helpful. And I was really lucky at the time that I was doing that work. I don't think people who are doing the same kind of work in New South Wales have quite the same support that I experienced at that time.
Yeah. I think one thing that Andrea Landini mentioned in the last interview that we had with Rebecca Carr-Hopkins was that for him, he sometimes is aware that he's just not the right person to work with that
Mm.
particular family as well. And I think that it's quite reassuring to know that there are people like Andrea Landini who will feel like I'm just not the right fit for this
Mm.
family, and being able to recognize that.
Yeah, I think having the maturity to know you can't do everything
Yeah.
is a really important part of being able to have a long career in this kind of work.
Yeah.
And it's tricky actually, because in child protection, families will often say that the problem is the worker, and the issue is that sometimes they're right. And it's interesting how often the direction of work can change, because unfortunately workers are changing all the time. And you often see that a new worker comes in and, for better or for worse, takes a completely different tack with people. And sometimes that makes all the difference. You know,
Yeah.
people will say, nothing worked until I got this worker that I really could trust. And, you know, which of course is about feeling safe. You know, I felt safe with this person and I could tell them what was really happening. And I trusted that the things that they wanted me to do were things that were in my interest. And, you know, that helped me. I've met a lot of people who have benefited from child protection involvement, and who would say, although it was really difficult, actually, I am glad that they got involved, because things wouldn't have ended well if they hadn't. But they would always then have a story about a relationship.
Yeah.
You know, I haven't met anyone who went, child protection came along, they gave me some information, and, you know, yes, it was really serious, but I went off and sorted it out for myself. And I've certainly never met anyone who said, you know, this person came, they told me I was a terrible parent, and then I changed. You know, that I don't think that's the way change happens in the work that we do.
Yeah. I'm conscious of your time, but I have one more question that I'd like to ask you, and then I would like to give um, the people who are watching an opportunity to ask you
Yeah, that's fine.
questions. So my last question for you is one that I would like to feature on all of the DMM community expert interviews. So if you were on a dangerous desert island and you were there with 3 other people, what attachment strategies would you like for them to have?
Well, I definitely wouldn't want them all to be bees, because I'd be worried people would just be overwhelmed because of their lack of experience of danger.
Mhm.
Um, and I probably wouldn't want them to be too extreme, because I might find that too uncomfortable. So I think I'd like some variation. And I guess that reflects, you know, the really interesting idea that if you think about things from an evolutionary perspective, if people have strategies that have no use in terms of our survival, we wouldn't expect them still to be here.
Yeah.
And so, you know, we have this kind of idea that everything is needs to be secure. Everything needs to be, you know, stable and well regulated, but maybe that's not actually the case. Maybe someone who is able to be very task focused, because they're, you know, an A, and someone who's able to rev us up with a bit of exaggerated affect is really going to contribute to us being able to keep going. And it's going to make life more interesting than people who are just on an even keel. So I think that would be my response. I just like variety. That's the answer.
Can I press you just a little bit further and ask you which variety you would like, which particular strategies you're with? 3.
Oh, okay. Please don't hold me to this. I'd like things to
Then
stay
you
flexible.
live with them.
I think I think I would maybe I'd like an A an A2, because they would be focused on kind of keeping us comfortable together, even if that involved a bit of inhibition for themselves. I'd like I don't think I want a C2, and I don't want a C4, because I think they wouldn't contribute enough and we'd need to look after them too much. Yeah. So I'd take a C1 or a C3, and maybe I could have one B.
Okay, that's.
I'm going to try. I'd actually, you know, people often ask me questions, and I think this is the answer I often give, which is, it's a research question. I actually need the data. So I'm going to start with an A2. I'll take a B, and I'll take a C1, and then we'll need to give it a go, and then maybe I might adjust that. You know, maybe I might be more comfortable with an A4, an A2, and me. We'll go from there.
That's fantastic. Well, when you obtain that data,
yeah,
and let us know.
I promise to publish.
Thank you. That's been wonderful. Thank you so much for your time, Bronwen. So if anyone has a question, maybe if you could put it into the chat box, and then I will come to you. Clark, you do.
Hello. I can't see myself. I don't know if you can see me.
Oh, we can see you, Clark. We can see you and hear you, so that's fine.
Okay. So, Bronwen, my question is about cross-cultural issues. Just being so conscious that there in Australia, you've got a very multicultural country, and also a very ancient culture, indigenous, and also lots and lots of immigrants. And I was wondering how this shows up in your care index assessments, and what you need to train people to take into account when they're watching care index videos.
So I think the theoretical idea would be that that infants are born with a range of capacities, but some cultures will function in ways that promote some capacities more than others. And if you think about that, responsive versus unresponsive, sensitive versus insensitive, so some cultures will have some particular combinations of behaviour that are more common than others. So in some cultures, people will be more intense in the way that they interact with their babies. But as long as that isn't overstimulating and too uncomfortable, that will be fine. They'll be great. But if someone watches that, who's from a culture where everything is quieter and calmer and more predictable, they'll look at that diet and feel really uncomfortable. So I've trained people from Japan, and they look at some of the Mediterranean diets and find that quite uncomfortable, because it feels like it's really overstimulating. It's not actually the way that they would be comfortable parenting. But there's this wide variety of what works okay. So I think humility is what people need to start with, and just always asking the question, so does the baby like it? And what's the evidence that the baby likes it? So we have things we like to see. That's one of the challenges for people who are working with families, because we like to see them do the things we've told them to do. But from a care index perspective, what we're interested in is whether they get more able to do things that their baby likes, and what's the evidence that we see of that.
Thank you very much, Bronwen.
We have a question from Orin.
Yeah.
Hi, can you hear me?
We can hear you.
Yes, I can.
Okay. Do you want to see me? Okay.
Hi.
Hi. Sorry, the question's a little bit complicated the way it looks there. So I'm a health visitor working in Cardiff. So from my sort of professional perspective, you know, health visitors work across the spectrum of healthy normative through to clinical high risk. In the UK, we predominantly work with a medical model. So, you know, stuff like reflux and everything else is sort of supported really when it belongs, you know, when it needs to be thought of in a different way. But anyway, this question actually is about I work with a lot of refugee families, and what I find absolutely fascinating is that if they come from, so if I think about, we have a reasonably large Kurdish population in Cardiff. So, you know, not only will they have had the trauma of getting to the UK from various parts of Kurdistan, but obviously they have a long history of trauma within the population because of everything that's happened over the years politically. And yet, when they get to Cardiff, what, you know, the experience of the sensitivity that I say it is an experience, it's a real sort of feeling thing as opposed to just anything that you can see, compared to, so I think, you know, I just wondered if you can say, you know, that idea of having a sensitive parent-infant relationship and significant trauma around that relationship. So, for example, being a refugee, getting to the UK, and then how that sensitivity in the parent-infant relationship continues to keep them both safe and the child develop, you know, healthily in a social and an emotional way.
I think the thing I'd be interested in is the adult attachment interview, Orion.
Yeah.
So I think from the infant procedure,
yeah,
all we would have is information about how they are together.
Yeah.
And I think what would be really interesting is to hear that from the adult perspective.
Yeah.
I do think, I think sometimes the question to ask is what were people's early lives like? Because I think particularly if you had a village community, and I think we see this in Australia because we have a huge number of refugees from different countries here. I think just because you're a refugee now doesn't mean that your entire life was endangered. So I think there's a big difference between someone who's, you know, first 14 or 15 years happened in a different cultural norm to the one that they're living in the West, but happened somewhere where they experienced safety, where their parents were there for them, where in fact they had extended family around them, and those relationships functioned in a really positive way. You know, that the question is, you know, how did that work then when those things were taken away? And, you know, how did that culture work? And maybe for people who have simultaneously had safety in their immediate surroundings, but knowledge that sometimes things are difficult, but we can survive, maybe that functions in a particular way. That's the only way I can make sense of it. And I think, you know, I think when I talk with Aboriginal families in Australia, you know, in lots of contexts, not just in the child protection context, you get this huge variation between people whose lives were wrecked by the intervention of the state and people who managed to keep their children safe. And you often, not universally, I mean, there's people with incredible stories of survival who've been institutionalized and had really terrible abusive experiences. But you also hear these stories of people who've gone on to be great leaders in their community. And it goes back to their parents and grandparents and to the way the parents and grandparents were able to carve out something for their children, even in the middle of very difficult kind of political circumstances. You know, so it's always important to look at the multitude of journeys and not to assume that just because you're a refugee, we know that you have been completely incapacitated. And then what's interesting is, you know, looking at those differences between people who are managing to parent really well and people who on the face of it are from the same place, who've been through the same refugee process and who are in a very different situation, and looking at to what extent some of that actually goes back to some of their earlier childhood experiences, and that maybe even within their own community, they didn't have the experience that their community would have wanted them to have.
Thank you.
Bronwen, do you have time for one more question?
One more question, yeah, thanks.
So we have one of our members who would like to address a thing. I would like to pronounce your name, but I would be destined to mispronounce it, so I'm not going to try.
No. So my name is Björk, and I thank you so much for this really nice lecture. The thing is, like, with as you just mentioned, with the infant care index and also the toddler care index, is when you have the high-risk cases scoring from 0 to 2. And I found it very interesting because when I was working in the child protection service, we were often like having a lot of expectations to people who were scoring so low. But I found it very helpful. At least you can't work with the parent and the child at the same time. When you have such a dysregulated parent who is, the stress system is so high, dysregulated. So I found it very interesting because we have a lot of, if you have a parent in that situation in the child protection service, which is on the edge of losing the child, we often like put them to parental trainings where they're able to be like parrots, learning a lot of things, but they are not emotional available and they are not taking in those. So, and they often get to keep their child, but they aren't managing it well in other ways. So I find it really interesting. So
thanks for that. And look, we have the same challenge in Australia. You know, I think the difficulty is that as service providers, we often want to give parents the things that we like doing. So we like doing parent training. We like putting people in groups. And the difficulty is that in the group, you might have your child in mind, but you don't have to. So people can be fabulous group participants because the interaction is with the group facilitator. And, you know, people can be really attuned to what the powerful group facilitator wants to hear. It doesn't necessarily mean that's going to change anything about their interaction with their child. But it's really uncomfortable to feel that we might not be able to fix this with the tools that we've got. You know, so I think that's part of the dilemma in child protection, that it's hard and expensive to offer people really supported mental health interventions with support to people in their homes. That's really hard work. And it's a lot cheaper and easier to send them to a group program and for their child to be in childcare. So we don't have to deal with the discomfort of actually seeing what they're doing with their child. You know, so that's the dilemma, I think. And it's, you know, it's hard to engage parents in something that's going to be challenging and uncomfortable, you know, in that kind of 0 to 2 range. So, you know, I think it's a skill challenge for us as well, looking at what are the skills you need to be able to have conversations with people and create enough safety for them to be able to look at uncomfortable kind of stuff. But the amazing thing is that people can change. You know, I've seen people who have been very distressed and unavailable to their children, who have actually, you know, been able to make those changes. One of the challenges is sometimes that the time it takes to make those changes may not be in the time frame for the child. And I think that's the other part of that, is looking at who's in the family and who might be able to be involved in providing care for the child in a way that might keep the parent connected. You know, we undervalue the contribution of extended family in that work, and we don't necessarily support them enough to do that, when sometimes that's actually what's going to make the difference in terms of outcomes, I think.
Thank you, Bronwen. It's been such a pleasure to speak with you and to hear your thoughts about our species, how they enter the world, and the way that they interact with their parents. It's been fascinating.
Well, thanks very much for the opportunity, and thank you for the work you're doing setting up the community. I'm really looking forward to hearing the presentations that are coming after me.
Wonderful. Thank you.